Good morning. It's a real pleasure to be with you all. So basically, we're going to just go to the basic, really. No financial interest. Basically, as we all discussed today about a lot about ocular surface disease, covering the conjunctiva, cornea, tear film, as is very important. But to assess the ocular surface disease, the staining is very important and very non-invasive way to check the ocular surface. Still, that help us to assess dry eye, ocular surface disease, contact lens complication, fitting, and post-surgical assessment. Regarding the staining, it's as you know, it's very simple tool we're using, and it's in our hand. Most of us really using fluorescein. As you know, fluorescein it's staining the damaged epithelium defect, and that it also assists the tear breakup time. We're using blue filters, and then we can assess the epithelium integrity. Nowadays, it's many of us also using lissamine green, but with advantage of lissamine green, it also stains the dead cells and damaged cells. So it's not like the fluorescent, using the color green, and also stain the conjunctiva. So the fluorescent usually stain mainly the cornea, but the lissamine green stain the conjunctiva. And the other one, the rosemary gold, which is really similar to lissamine green, it also stain the dead cells. But nowadays we least likely using it because it's stinging more. So most of our using fluorescein and lissamine green to assess our patient for ocular surface disease. One thing which we in the clinic when you use the fluorescein, I found many people using like 2% staining drops. That's too strong. You cannot expect to see good staining with that. So the concentration of the fluorescein is very important. If you're using too much of it, also it doesn't give you a good staining in the, and you become faded. The other things also, fluorescent, when you put it, it's fade very quick. So you need to assess the ocular surface fluorescent staining very quick. But in the other way, rose bengal and lissamine green, it can last longer. So if you want to take a picture with the patient, especially, is nowadays really good to take a picture to demonstrate it and document, and also for follow-up. Always my patient asks me, how is it? Is it better, not better? I always go to the picture before and show him the old picture and the new picture. So for fluorescent, it's very good to do a picture quick. Otherwise, you're not going to have a good staining. Same thing, so my colleague asked me to see this patient after 10, 15 minutes. It's difficult to assess that time, how is the staining. And so timing is important for fluorescent, but lissamine and rose bengal, it stay longer. So you have more time. So I'm mainly talking about the pattern for stain and the significance. So the staining, it can be different area of the cornea, and they have this different significance for different location. So inferior corneal stain, it's usually common in the blepharitis, blepharoconjunctivitis, lag of thalamus with exposure keratopathy. If someone had tracheasis, rubbing in the cornea or conjunctiva, trachoma, all that's indicated more of tear instability, but also element of exposure, or patient doesn't close his eyes. The interpupillar pressure, it's like we see the staining mainly in the like a zone 1. Is more of a dry eye, meibomian gland dysfunction, and vitamin A deficiency. If someone patiently have a mainly stain in the superior cornea or conjunctiva, that's you looking mainly superior keratotic conjunctivitis, could be related to contact lens and mechanical rubbing or tight lens. Regarding if someone had diffuse, really, if someone had very bad severe ocular surface disease, or that would become all diffuse stain, but it could be viral conjunctivitis, toxicity, pattern. Patient who had central staining mainly, more related, could be toxic, preservative related keratopathy, but very common we see it, people, we do a lot of refractive surgery, we're creating our patient dry eye. So after LASIK, also after BRK, cross-linking, because we really damaged the central epithelium, so we had this more central staining, and contact lens overwear can also present a male pattern the central staining. Peripheral corneal stain, it's a sign of margin keratitis, limbal cell deficiency, contact lens, environmental, wind and other, that could be a factor. But also when you look at the staining, it could be different pattern really. It's like a banked stain, central abrasion, like bubbles. It could be abrasion lines. It could be like this batches of staining at 3 and 9 o'clock. So there's different architecture, different pattern, and different disease can be associated with it. Regarding the conjunctival stain is very important. Really, we concentrated in the cornea, but also the conjunctiva is very important to look to the conjunctiva, look into the stain. So nasal tuber conjunctiva, that could be early dryness. If someone had bengucular irregular surface region, also you could have punctate stain. This is why patient complain of irritation, because it's not smooth ocular surface. So you had this corneal erosion of punctate erosion in it. Superior palpebral, usually typical of superior limborectal conjunctivitis. Ask the patient to check for thyroid disease. And inferior conjunctiva, usually talking about blepharitis, chalasis, and exposure. Regarding the quantitative, how to assess and what system we're using for scaling, the Oxford scheme, that's the oldest one. We use it, many of us using it. You could use National Eye Institute or Van Biskerstraat score. So basically, Oxford scheme, that's just you had like a picture, and then by our brain now you get used to the picture, how many dots we see, and refer to the grade, absent, minimum, mild, moderate, marked, severe. But you don't. So we compare the picture. That's good for when you take a picture of the patient's slit lamp. It's really give us that's the comparison for the, and you can put the scale what you want to do. National Institute is different. So basically we divide the cornea in 5 zones, and every zone looking for dots, how many dots in every zone. So it's 1 to 15 dots, like a grade 1, 16 to 30 dots, grade 2, and more than 31, grade 3. And then you calculate the total, which the total 15 score. Because it's a wider area, so there's some advocated modified NEI grade where you're just going by half steps. So not 1, 2, 3, so 1, half, 1. So, and that's you count then the spot, how many spot, and looking for the total. And Van Pastor score, always difficult to pronounce his name. So basically he looking, that's the one who score included the conjunctiva. So he divide the 2, 3 zones, and every one scale from 0 to 3. So nasoconjunctiva, cornea, and tuberal conjunctiva, and anything grade more than 4, that becomes clinical significant. So usually the stain is very helpful, but you need to combine the stain with all the talking about it, tear breakup time, Sherman, myopography, osmolarity, maybe not all together. That will help us to compare the dry disease diagnosis and monitor and help us to decide the treatment. Summary: ocular stain is a cornerstone for diagnosis. Is very simple. We are handy for us. You don't have too much machines, anything. So it's very simple. But when you put the stain, you need to choose the right stain to examine, and also the timing is very crucial, and the concentration. I think that's very important. The pattern also will give a clue what's the cause, what's the disease mechanism, severity, but also when you assess it, you can see the response of any medication you use. You need to integrate this staining with all other modern diagnostic tool, osmolarity, biography, infrared, inframeter, and that's all give you better assessment for the patient, and that will give you better care and better way to know that he's better. And thank you very much.